Well, thank you, David, and thank you for coming. I'm delighted to be here. Liverpool Hope University is on my map because of David. And meeting him yesterday, I have to say, I was taken aback a little bit at how young he is. And I thought, I think if we'd known his actual situation when he proposed all of this, we might have been a little less happy to endorse it. So he had the advantage of stealth, But I only know of two people whose last name is Bolt. One is David, and the other is
Hussein.
Yes. And as far as I know, they're not related.
Yes, me bosom.
But they both get things done in a hurry. And I was saying yesterday that I've never seen a journal develop and come to be so quickly. It's quite a feat, especially today, I think. And, I felt like I was tagging along on this trip rather than, I can see why it was useful to have the endorsement of people like me, but, he started it. He saw the need, or he saw the possibility for this journal, which I think was a really good idea, that it hadn't been a journal which focused on what it focuses on, literary and cultural, disability studies. And he made it happen, so I was glad to be here at his invitation and to meet him finally. And anyway, so I'll give my talk, and I think we should have plenty of time for questions. My topic is narrating disability inside and outside the clinic, and I want to explore two distinct, my talk really has two halves. There's going to be two distinct matters, each of which I think has ethical dimensions. What happens first when clinical narratives of disability go public? And second, what happens when disability and illness are conflated within the clinic? So there'll be two quite distinct parts to the talk, but I think there is a connection. Now, I'm going to be addressing some moral hazards inherent in life writing about illness and disability, but before I do that, and because I'm doing it, I want to be clear that I don't want to do anything, I don't want to say anything that would discourage the writing of life, the practice of life writing about disability and illness. I've devoted the latter half of my career to reading and writing about published narratives of illness and disability, and I wouldn't have done so unless I found these narratives compelling. I really began this work about 20 years ago now, in the mid-90s. I noticed that people were publishing lots of narratives about illness and disability, and I began to read them and write about them, and I found myself, literally without knowing it existed, in the field of disability studies. But the writing of such narratives has continued to proliferate, and I've argued in various places that the so-called memoir boom in the US and perhaps in the UK as well has coincided with, and to some extent been driven by, the rise of such narratives. I have compiled a long list of conditions from anxiety and autism to Tourette's and vitiligo that have generated memoirs in the last 20 years, and the list continues to grow. Recently I came across a book review of 2 narratives of amnesia. Think about that. How do you do it? Well, you interview people who knew you before your amnesia struck, and what a great project that is. I mean, that's how you find out who you were and who you are, and it becomes a necessarily collaborative project. And anyway, whether inside, you could say that the illness narrative or the disability narratives have been something of an American literary epidemic. Some people think it's, it's gone too far, we have too many, but I don't. Whether inside the clinic, such narratives can be in and of themselves restorative, if not healing. In her introduction to Depression and Narrative, Telling the Dark, Hilary Clark said it well. We should listen to personal narratives of illness and disability, really attending to them and their own merits, as opposed to using them in order to come to diagnoses and impose regimes of treatment, because such narratives give voice to the ill, the traumatized, and the disabled, those trying to make sense of the catastrophic interruptions or shifts in their lives, and help them navigate the bewildering, impersonal context of medical diagnosis and treatment. And one of those traumatic experiences would be, or catastrophic interruptions would be, the onset of amnesia. So please don't misunderstand me. Nothing I say today should be construed as intending to discourage writing about illness and disability. I'm only concerned to point out certain dangers that are inherent in this endeavor. Inside the clinic today, psychiatry, as you probably know, is moving away from narrative therapy toward drug therapy. As this is happening, interestingly, narrative competence is being emphasized, at least by some, in the treatment of non-mental illness. I refer here to the clinical approach known as narrative medicine, as advanced primarily by Dr. Rita Sharon. According to Sharon, the narrative approach elicits, quote, accounts of self that include emotional, familial, aspirational, creative aspects of the self. Thus, in narrative medicine, a physician's relation to her patient's approach is that of a psychotherapist. The aim and claim of narrative medicine is that it recognizes patients' full personhood, addressing their illnesses as part of multidimensional life narratives. So far, so good. But greater knowledge of patients' lives can enable the writing of invasive case studies. Indeed, in a paper given at a 2000 MLA convention in a panel I was part of, Rita Sharon herself acknowledged this. Her title, Listening, Telling, Suffering, and Carrying On, Reflective Practice or Health Imperialism, indicates the possibility that rather than empowering patients, narrative medicine may amplify the power of clinicians at the expense of patients. It may thus increase the risk of what I call deferred iatrogenic pain. Iatrogenic pain, as you may know, is pain caused by medical treatment. And I coined the term deferred, or maybe I should have said referred, iatrogenic pain, to refer to suffering inflicted on patients not by their treatment, but by narratives of their treatment. This can happen when the boundary of the clinic, always porous, is breached. Stories that originate in the clinic can cause pain to patients or their families when they're encountered outside the clinic. Consider this case. When I was speaking at an American university a couple of years ago, a student approached me, a graduate student. At the age of 7, I'll call her Julia, she was operated on for significant physical impairment which required ongoing medical attention. To help her cope with this regimen, she was sent to a therapist. Nearly 2 decades later, learning that the therapist had been appointed to a prestigious academic post, Julia looked her up online, just out of curiosity, as anyone could do these days. The therapist's resume listed an article Julia thought might be about her. Reading it confirmed her suspicion, and she found it deeply unsettling. This anecdote illustrates, for starters, how the internet has shrunk our world. We all have less privacy than we used to, and it's ever easier to trace others and references to ourselves. Scenarios such as Julia's, however, don't really require the internet. The New York Times has an ethics columnist, and someone wrote to him a couple of years ago saying that he was browsing in a bookstore and